Good, uh, good afternoon, everyone. I hope you've been having an amazing time here at GS25. I want to say a big thank you to the organizers, our partners, Policy Innovation Center, for this opportunity. So my name is Kemisola Agbaoye. I am Director of Programs at Nigeria Health Watch, and we are co-organizing this session with the Policy Innovation Center themed Reclaiming Safe Motherhood while women are still dying in childbirth, systemic barriers, and the case for MPDSR reform. So we have a short video that we wanted to play just to set the tone for the conversations and to help you understand what MPDSR is. MPDSR stands for Maternal Perinatal Child Death Surveillance and Response. If we could please play the video, that would be great. It's a short 3-minute video. Okay, so while they prepare the video, there are some statistics that we are all familiar with, or I assume a lot of people are familiar with, that looks at what the state of maternal health in Nigeria is. We have, as of 2018, as of the National Demographic Health Survey data of 2018, we have over 500 maternal deaths that happen in Nigeria for every 100,000 people. That number has climbed in recent times, but seeing as we're still finalizing what our national position is on maternal death now, we can say it's well over 1,000. Now, to bring that home, that means at least one woman dies, while 1 out of 100 women dies while giving birth in Nigeria. And there's just simply no justification as to why women should die while giving life. Now, if you were to look into what has happened in the maternal health space over the last few years, you'd see that in 2022, there was a bill to legislate MPDSR. MPDSR essentially means that the reasons why women are dying while giving birth are investigated and looked into. Most women in Nigeria give birth at home. MPDSR is something that our country has taken on over the last few years. We have guidelines, we have procedures, we have exemplar states that are doing very good work in this area. And on this panel today, we have 2 of such states that will be sharing their lessons with you. MPDSR is also currently being implemented by the National Primary Healthcare Development Agency. This is something that has happened in certain pockets and in certain states over the last few years. But now, with the new administration, there's a push to legislate and formalize and properly coordinate MPDSR nationally, as well as subnationally. The government is also pushing key reforms. Maternal health has become of utmost priority to this administration. So there's the maternal mortality, Maternal and Neonatal Mortality Reduction Innovation Initiative, also known as MAMI, that the government is currently implementing. So what MAMI does is look at the 172 LGAs, local government areas, where there is the highest level of maternal deaths across the country. And these LGAs have been selected across 33 states in Nigeria. On the panel today, you'll have the NPHCDA focal person who is driving both MPDSR implementation and MAMI implementation nationally. Those are the people that you'll be listening to later. So maternal health is priority. Maternal deaths is an emergency. How many of us have seen that video? The video where there were lots of celebrities and a lot of pregnant women, and they all went on an aeroplane. How many of us have seen it? I see a few hands. Okay, so try to imagine that number of women die every day in Nigeria due to or while giving birth. Let it sink in. When Sosoliso happened, a lot of us got really emotional, right? When there was a Dana air crash, there was an outcry. That's how angry you should get when you hear that a woman died while giving birth in Nigeria. My mom told me a story once about how when she was pregnant for me and she went into labor, she started to bleed profusely. and she was rushed into one of the general hospitals. I think now it's a state teaching hospital back there in Lagos. And she went through a harrowing time. So every time, and you know how African mothers can be, every time she wants to pray for me, she remembers what she went through while giving birth to me. But the morale there, the story there is that she's still alive to tell that story. She found healthcare. She was able to access care. And I'm here. I didn't die. 36 or so years later. So MPDSR is an imperative. There was a bill that was being pushed by the then Senate Committee on Health as far back as 2020 that passed a number of readings, I think 3 readings at the National Assembly. And then in 2022, almost got assented. But with the change in administration, that stalled a bit. And there's been a lot of work to try to push that again now. So I hear the video is ready. In 3 minutes, we're going to watch this quick video, and then I'll introduce the panelists, and we'll have our discussions.
Maternal death audits have emerged as a vital tool in understanding and preventing maternal deaths and is linked to quality improvement in maternal health care. MPDSR is a World Health Organization global recommendation adopted by Nigeria.
MPDSR, that's the Maternal and Prenatal Death Surveillance and Response, is actually a very essential intervention that improve quality of care to ensure that maternal and newborn health are improved. However, what happened in MPDSR is just we go through a process of identification, we notify, quantify, as well as try to determine the cause of underlying death of maternal and newborn, and also try to find out how to avoid subsequent or future deaths from those related causes.
So when you are able to identify the causes, what next? So we are also going to use this information to prevent future occurrence. If we know that the problem the last time was delay in getting to health facility, we can now say what caused that delay. Oh, the road is bad. We can now take advocacy to the right people to fix that road.
The process of even advocating for an act for MPDSR was also a success story in the sense that relevant key stakeholders, including WHO, was able to push this agenda with the leadership of the Federal Ministry of Health. And we've been able to actually pass the first level of being able to put that as a bill. And at the moment is in the senatorial different level of review in the last administration. And we hope that in this current administration will be able to move it from beyond a bill to an act. And because that document is more like a legal framework that was able to clearly define what the roles of the different key stakeholders are around MPDSR. And that document is also being able to say, oh, if we're able to hold ourselves accountable on issues that have to do with maternal death. Is the key. Maternal death is actually a universal emergency, one, and is highly unacceptable. And if we have a legal framework that speaks to that and holding every stakeholder accountable, I think for me is going to be a good success story.
Passing the MPDSR bill into an act will serve as a legal framework to enforce that every maternal death, wherever it occurs, facility or at community levels, is counted, reported, and examined, and that the findings from these audits are used to drive action to prevent future deaths.
Thank you so much. Hi, everyone. If you could please move forward so that the front seats can be filled, that would be really great. Thank you so much. Please occupy the front seats. All right, so I'll proceed now to introduce the speakers for this session. I'll start with Mansoura Yahaya. She's the State Maternal and Child Health Coordinator for the Kano State Ministry of Health. Please put your hands together for her as she comes forward and she takes the seat beside me. Right next to her would be Dr. Veronica Iwayemi, the Acting Director of Medical Services and Disease Control at the Lagos State Primary Healthcare Board. Please put your hands together for her as well. And finally, we have Dr. Muhammad Bello Garuba, the Deputy Director, Head of Health Services Division, and the lead of MPDSR and MAMI at the National Primary Healthcare Development Agency. Thank you so much. Okay, so I think we can start with you sharing your experiences implementing MPDSR in your state. So I'll start with you, Mansoura. So from the MAMI assessments, Kano has one of the highest rates of maternal deaths in the country, with the highest number of LGAs that are being targeted for the implementation of the maternal and neonatal maternal and neonatal mortality reduction innovation initiative. And you contribute over 50% of maternal mortality in Nigeria. So you lead MPDSR. You are the MCH lead at the Lagos State Ministry of Health, and you have been implementing MPDSR as a state, both at facility and community level. Can you share how this has impacted the maternal health rates? How you do it and how it has impacted the maternal health rates?
Okay. Thank you so much for this question. And as you rightly mentioned, Kano State has the highest number of LDS that contributed to the national maternal mortality and then perinatal mortality as well. We're having 18 local governments in Kano State with that. And then the good part of it is that Kano State has been conducting this maternal perinatal death surveillance and response since 2012, though it has started with just the MDR, that's maternal death review, while gradually it transitioned into the maternal perinatal death surveillance and response. And then how it has been done is that we usually conduct the MPCDSR at the facility level. We also have a gap of not conducting at the community level, but then perhaps we have plans and we started even the piloting in an LGA, though we had series of pilot about 2 years ago or thereabouts in 2 LGAs under the quality of care approach. So the thing is, in all the facilities where the death occur, we have a checklist, and we also do have the state MPCDSR committee. And in that state MPCDSR committee, the Honorable Commissioner himself is chairing the committee. And then on quarterly basis, this state team do go around the facilities that we have institutionalized the MPDSR committee at the facility level. So as such, all what has transpired during a quarter is being reviewed by the state team and validated. Then they also do send to the national platform, that's the NOCA, at the various facility level. So at the end of each year, that's annually, we conducted the review, whereby the Honorable Commissioner himself chaired that meeting. Usually we do have 3 to 4 days meeting, and all the facilities chairman of that MPDSR committee will be there, and we'll have a work plan for each facility. So during each mentoring session, that's on quarterly basis, we will follow up to see out of those work plan, out of those activities that they came up with during the annual review, been follow up and see how they do it. And another key thing is that, now the MPDSR at national level is being integrated with the quality of care. Mm-hmm. So Kano State, I think, is one of the states that had that training, whereby all our mentors, that the state MPCDSR members, as well as the quality of care members, are being trained, that's the TOT, including the facility level, even though that is only at the learning side, that's the quality of care learning side. But perhaps the MPDSR really helped the state to see the main causes of this maternal mortality and perinatal mortality. It also gives us an avenue to prevent future occurrences. And then we also help the facilities to plan, because each of the facility you might have a few peculiarities of the causes as well as the social contributing factors of that maternal mortality. So far, Kano State is doing well, and we also have plans to do well, especially with the MAMI and with the help of the NPHCDA to kickstart the community component of the MPCDSR in Kano State.
Yeah,
So
thanks.
thank you.
Thanks so much for sharing that experience. Dr. Iwayemi, Lagos is, always center of excellence. This is not to look down on any other state, but I mean, when people speak about MPDSR, both of your states come up a lot about how you've been able to get a lot of results in driving MPDSR and how that is helping drive down maternal mortality. So can you share what your experience is?
So with Lagos State, what we understood was that we needed to move from just gathering or collecting data to actually acting on the data. We had data for women that were dying at facilities, and so we understood that at this point, we had to address the barriers that were already on ground. So we identified one. One of the barriers was the fact that there was this culture of silence and fear. The healthcare worker did not want to be blamed for the death of the woman, and so there was a need to sensitize, to understand that we needed to move from blaming to learning. The essence of MPDSR was to learn what could we have done better. This woman didn't need to die because most of these deaths were preventable. And so when we sensitized our staff, our skilled birth attendants, to understand that we're not here for punitive measures or to blame, we were able to get them to be, we're able to institutionalize actually the operations of MPDSR. That was the first thing. Then we understood that we needed to have in place foundational structures. So we set up committees because, again, we needed to be able to review this data, not just collect it, but analyze it and find out what are the trends that we're seeing. To do that, we had to establish MPDSR committees at the facility level, at the local government level, and at the state level. So having done that, we also had to train. So take, for instance, at the secondary health facility, we now had maternal perinatal death surveillance officers. Whether they died, whether the outcome was negative in terms of we lost both the mother and the child, there would be an officer that would collate the data for the perinatal and an officer for the maternal. And that would be the one to generate the review meetings at the ending of the month. Having done that, we now moved on to understand that we had to also institutionalize the whole process. And that meant that we had to involve community structures. We haven't gathered data. We were seeing the trends at the facility, whether it was infrastructure issues or facilities that had recurrent delays. We were now identifying high-risk local governments. And so we had to start using the data for decision-making. What were we going to do? If this facility was having recurrent delays, how could we mitigate against these delays? If the delays were based on capacity, the skills of the healthcare worker, then we addressed by building their capacity, whether it was in terms of BMOC training and all, or respectful maternity care, depending on what the trend was showing us from the data, we addressed those as well. And then we now saw over time that we had gotten the hang of facility maternal mortality review, right? The MPDSR committees were now persistently and constantly reviewing their data. But there was a gap, a surveillance gap, because women were still dying. And we saw that we didn't have data for those dying at the community level. Those who, either for one reason or the other, didn't think they would need skilled birth assistance, or they made the decision late, and between them deciding to go for it, there was a delay in access to care, or there was no facility within their settlement, or they couldn't afford it. So we understood that we now needed to do community surveillance to see what was going on. Because yes, we knew what was now going on at the facility, but yet women were dying. So we now went further to institutionalize and say, we have no data for that. So Lagos State decided to conduct what we call the Lagos State Verbal and Social Autopsy Sample Registration System. Because we found out that it wasn't a norm to report a woman that died at home while trying to give birth. And so we now had to even go home. We educated, we trained some data collectors to go door to door across our 20 LGAs, wherever we had reports of maternal death, whether we did retrospective and prospective. And so we gathered data. Because what we wanted to do was create a sample registration system where people were reporting any woman that died in the community, whether at home, on the way, or even at a TBA. We just needed to have that data to see what's going on at the community as well.
Okay.
So we have that already in place now. And then we started using the data. Remember I told you at the first time that we weren't just collecting data, we were using it for action. So we now use the data to advocate for budgetary allocations for MPDSR. And so with that data, we were able to convince the legislations and the government to provide a budget line for MPDSR, which we have now.
Oh, wow.
And yes,
that is very, so thank you so much. I think that really situates the reality in Nigeria. So we have over 50% of our women who actually give birth at home. Facility-based reviews just don't cut it for this context. Yes. I'll come back to you because I'm very interested in hearing, if there's time anyway, very interested in hearing more about about what your data is saying about how women are dying in communities. But I wanted to come to Dr. Bello there. So you've heard from Kano, from Lagos, two excellent exemplar states that are already driving MPDSR implementation within their context and at the subnational level. Now, you work at national level, and you know that not a lot of states are currently implementing this. How is NPHCDA driving the legislative push, trying to get a lot more states to start to take such reviews seriously? And the second part to that is, how are you integrating MPDSR, maternal death reviews, etc., into the implementation of MAMI? I know it's still at infancy stage, so if you don't have clear examples yet, happy to just hear what your thoughts are.
Okay, thank you for having me. Is it? You see, the idea about MPDSR is shifting the focus from maternal and perinatal death as numbers towards seeing it as a serious catastrophic event that we need to respond to. And we do that by looking at the causes of this death as multifaceted, different layers. The first one is at the family level, at the individual level. Second is the community, and then the facility. Now, when you have a problem that has these multiple layers, you have to approach it also in a different way, integrating various interventions that you have to address all the levels. And this is what we do as primary healthcare integration. But then I want to point out to the fact that implementation of quality of care MPDSR in the country is the best example of one conversation. At the national level, we have synergized between ourselves, the agency and the federal ministry. None of us is working in silos now. So we coordinate our activities with the various stakeholders to approach it. Right, we have our responsibility to push the implementation at community and PSC level at MPSCDA, where the ministry pushes for the secondary and tertiary level, and then do the coordination activity. So we have a harmonized national implementation framework. We also encourage peer learning between the states. We have quarterly zonal review meeting. We have a dashboard that state will come and tell us the level they are, and then they compare their performance with their peers. So that peer learning tend to encourage states to stand up to their roles and responsibilities. We also work toward ensuring resource mobilization. So we have these resources for you. if you are able to demonstrate that you have established the framework and structure to be able to respond, because MPDSR is more than numbers. Okay, here is it that we have resources for you if you demonstrate that you have the mechanism to respond to the various causes that will be identified, and we will give you the technical support to begin the processes and then harness the resources for you to do the implementation and some part of the response. This is the second way. Third is to ensure that we operate an integrated planning and implementation of our interventions that will resolve the issues at the various levels. MAMI, as you have mentioned, is a paradigm shift to how we do programming. Prior to this intervention and initiative, we look at maternal death as numbers, and we look at pregnancy and other events as numbers that we can calculate in any table. But in MAMI, we are saying no. These are human beings and citizens of Nigeria that owe us the responsibility of protecting and making sure that they live a decent and productive life. So we go house to house to enumerate the pregnant women so we know them by name and place of residence. We send community-based care workers to identify their need to be able to deliver a healthy baby in a condition that is hygienic and safe. And then we provide them the services they need, either at the home or we link them to the facilities. And then this is where the first change stops. The second level of change is we follow up these pregnant women. Earlier, nobody is concerned at which gestational age a woman starts her ANC. Nobody cares. And if she attends 1, 2, 3 times and she stops, nobody cares. She attends ANC but decides to deliver in a prayer home or at any other place, nobody cares. Now, the second intervention we are bringing in MAMI is to follow up these pregnant women as they are linked to facilities. We monitor her utilization of the services. If there is any default, then we send these community-based care workers to her and find out the reason and try to resolve the reason and link her back to the facility.
Okay.
The third one is to have birth preparedness and complication readiness. How do you do that is by engagement with the pregnant woman and influential others, that those people in her family that influence her decisions, to determine where to deliver and guide her to deliver in a facility in an integrative way. And then identify the facility, try to know if they have what it takes to provide the services, to do risk assessment, and then help her to anticipate possibilities of complication and prepare for it.
Okay, thanks so much. I think that, thanks for just really doing a deep dive into how you are thinking about and how you've changed how you engage with women and the mothers within the communities. I'd like you to speak to legislation and compliance, if you can. Lagos is already, you've gotten a budget line already for MPDSR. You are pushing a bill already as well, trying to make it law and mandate people to report these occurrences. What are your thoughts on how we can make this cohesive at national level? How can we get more states to be as invested as these 2 states are in MPDSR? What is the case for legislation for MPDSR from your perspective?
Okay, so maternal death review traditionally is a clinical audit if the death occurs in the facility. And then it tried to do grid analysis to identify if there are any quality gaps that can be filled. There is this tendency to hide any gap because of the fear of probably litigation, or even among your peers, maybe it shows weakness in skills. So there is this hesitancy in healthcare workers to open up and explain what happened in the circumstances that led to the death. So there is need for any system to encourage reporting, review, and response, to have legal framework that protect the practitioner to be able to open up and describe the process that led to her death. So this is very critical. 2, The problems that lead to maternal death occur at different levels. There is one seminal work by Deborah Men and Alan Rosenfeld that describe the path a woman follows to death due to pregnancy, delivery, and puerperio. And there are several checkpoints, let me put it that she has to cross to that. Now, you need a legislation that will mandate responsibilities for several stakeholders at those different checkpoints so that we can hold them accountable. There are specific roles and responsibilities for all of us that need to be stipulated as a national law. Now, we have reached an advanced stage in the 9th National Assembly to have this bill passed, and we missed the opportunity when the last administration took the bow and we didn't have it signed. Now we are reflecting back, trying to make it more inclusive, try to identify the gaps that led to the delay in passing of that, and then making the environment, the enabling environment, so that we are not only doing legislation, we are being holistic in the way we see it, so that the bill will be like a tool that will be facilitating action. We will not wait to look at it as a punitive measure. It is a bill that is a policy document that will specify roles and responsibilities, earmark resources, and give responsibilities and then consequences for inaction. So we are going back in the spirit of SWAP, engaging all the stakeholders and doing our homework so that when it passes, it is ready for implementation, for action, and results.
Thank you so much. I'll pause now for maybe one question or reflection from the audience. Is there anyone who has a burning issue? Oh my God, there are like 3 hands. Okay, so I'm completely out of time. So I will take the first hand I saw. And if I get a signal somewhere down the line that I have a bit more time, then I'll take a few others. Can we get a microphone to her, please? That was the first hand I saw, sorry. The lady, yeah.
Okay, thank you very much for the opportunity to ask this question. So when he was talking about the service uptake, I was just thinking around like factors that affect or barriers to actually accessing the services. And I was thinking about like a contextual factor, which has to do with like the very patriarchal context we have. And we know that there's overwhelming evidence that sometimes a major barrier is power dynamics in the household or gender norms, social norms rather. So I want to ask, what is being done to address this? Because especially in the north, I'm from the north, is a major problem. Like if the man of the house says not to access antenatal services or maternal care services, the woman would not. And you know, these perceptions are, or these rules are made based on perceptions basically. So what is being done to facilitate like this kind of male allyship, you know, to increase service uptake? Because whether we like it or not, this is a major factor. I mean, I'm talking about context, so I want to understand what's being done like when it comes to like the power dynamics in the household and the social norms generally.
Thank you so much. So I'll take one more, actually. I'll take from that gentleman there, and then I'll let them respond, and then we'll wrap up. Apologies to the organizers. I'll try to wrap this up in 5 minutes.
All right, thank you very much. My name is Musa Ismail. So mine is about, let me say, a form of gender-based violence that women face in healthcare settings. It's termed obstetric violence. And this question is going to the coordinator and also Dr. Mansoura from Kano State, because I think one of our recent studies find out 65% of women that visit facilities for antenatal, or maybe postnatal care, or maybe for labor, experience obstetric violence. And one of the things that was coming out again is that these women are reluctant of going back to hospitals. And it's like we are going back, we are retarding in terms of any intervention of encouraging these women to go to hospital. So what are the major steps, or maybe let me just say remedies to reduce that obstetric violence in our healthcare settings? Thank you.
Thank you so much. Okay, so you heard the 2 questions. First question is about power dynamics, partners and their role and how they are being involved. The other question is about obstetric violence, I'm assuming within the facilities. Yeah. So I would like for each of you to reflect on those questions and answer as well as say your thoughts on what the case for legislation is, so both at subnational and national level, and just end with what your clear recommendation is. So if we're going to really implement MPDSR in Nigeria, what's the topmost thing that you think should be top of mind for everyone, as well as responding to those questions in exactly 1 minute?
Wow.
Yeah, so we'll start with Dr. Bello.
So you see, there is an internal and external factors that we push to address this social determinant of health. You see, the worth of a woman in any community determines how we relate to her and her ability to take critical decisions at the time of need, especially for healthcare. So internally, for MPDSR, we encourage social autopsy, where quarterly, according to national guideline, a community outlined as a political ward will sit down during WDC meeting, and then we bring all the cases of maternal death and the circumstances that led to their death. And then the community, we try to find out the various problems, including cultural norms, religious factors, environmental factors, and then we use the tool to empower them to identify practical solutions that is locally brought to be able to make them to realize the need to act. And this is the most sustainable. But then going at the country level, we need to invest heavily on human capital. There is very compelling evidence that shows any year a woman spends for primary school is associated with % decrease in potential of her to die in childbirth. And then any lady that has spent any year post-secondary school, the chances of her dying in childbirth, preparium or delivery, will decline by more than 60 to 80%. So lasting solution is to invest in human capital, ensure that ladies are educated, they stand the potential to live a life like any other person, and then they will be empowered, and we will have this problem resolved.
Thanks so much. That's Wayemi.
Okay, so I'm going to make it brief. So for Lagos State, it's worthy to note that we actually have a Lagos State Domestic and Sexual Violence Agency. So in addressing, I'm going to start with the question of how do we address violence in the hospital. Now, what we've been doing is we're training and retraining our staff on respectful maternity care so that we learn how to respect the client and also give them quality care management. Now, in terms of how we're addressing the cultural barriers and the community aspects, we've started what we call Men in Maternity. We understand that we must have male involvement. And with Men in Maternity, first of all, I want to say kudos to our partners, Project Aisha, who have been helping us in capacity building of our healthcare workers, and also in the implementation of community MPDSR, which we're doing in Lagos across 2 local governments right now. Now, for Men in Maternity, we've bought what we call the Empathy Belly. It's like a simulator. So we have community engagements with men. It's a fun time. They come in and we make them wear this simulator. And we have Iran, Buba, everything. And in 1 second, the man is transformed into a pregnant woman. It stimulates even the effects of pregnancy, the full bladder and all. So while they're learning that pregnancy is something that this woman needs to take a break from. She needs to have skilled attendants for her delivery. They're also learning to be empathic towards their wife. And so when we now say this is why they need to have skilled birth delivery and also antenatal care and postnatal care, they understand because now they feel the effect. One of the men said, is this what they go through? And we had him lying down, then we now knocked on the door and said, get up. And he was like, And we said, no, you see me. Don't detail, Jerry. And it was fun. But it was now like, oh my God, is this what okay, my wife will be coming for antenatal care. So we can only get things done by making the community also experience the challenges we're facing, so that we're not just saying it, but you understand now why we're saying we need to go this way. And then, of course, we're building trust, because people don't trust government. But with this, they understand we're looking out for their best interests. And then as per policy, my one statement is, we understand as a state now, we must have state-level policies that link community MPDSR and MPDSR. That is for continuity, so that irrespective of whichever administration is in government, once there is a law mandating reporting of any death, it stands. And then we can actually start asking for data, more data, and people get used to this as a country and as a state. Thank you.
Thank you so much.
Okay, thank you so much. So I think I will not waste much time, because I can see clearly from our discussion that Kano State and Lagos State are like twins. So majority of these are also happening in Kano State. But then I will retread. The only differences is where we tackle the issue of respectful maternity care. We also embedded in all our CMONC and then our BMONC trainings. We incorporate a particular presentation on that respectful maternity care. And we also do conduct client exit interviews to hear from feedback from the pregnant women, so that we can see where we can also act upon. Then another key thing is in Kano State, thanks to our partners, especially CHAI, where they supported us, we conducted what is called group antenatal care. There is a particular day that any male involved, there is a particular day where we invited the male, as well as any lawmaker from that household, to be part of the antenatal care services. And it's all similar to what my colleague here have already said, so I will not waste much time. Then for the last statement I'm going to make is, I think this maternal and perinatal mortality is not just a statistic. So we need to learn from this loss, and we make the loss into learning, and the learning into action. By so doing, we are going to prevent all preventable maternal and perinatal death, and this can only be achieved by legalizing it, making it a policy in all our state and at national level as well. So thank you so much.
Thank you so much. Can we do a quick poll as we round up? Yes, I know my time is up. Do you know anyone that has died in childbirth? Can I see your hand up if you know someone that has died in childbirth? Wow. Okay. So do me a favor. Go on social media. Now you've heard about MPDSR. You've heard about what it can do. There's already evidence of how it is crashing maternal mortality rates, not just here, but in other African countries as well. There are whole counties that have recorded 0 maternal mortality deaths in countries like Kenya, Uganda, where people are intentional about this. They understand the value of verbal autopsies, social autopsies, investigating why a woman should die. Someone was telling me about, I think it was Dr. Wayemi that was saying when she visited Mozambique recently, the communities actually expect it, that when a woman dies while giving birth, governments will show up and ask why. And there's a no-blame policy. No one is blaming you. We just want to know why it happened so it doesn't happen again. We've seen how this is a multi-pronged issue. There are so many things to consider. Dr. Bello graciously told us about all the different things and all the different steps that are taken to make sure that women are carried from the point of pregnancy and then they come out of it with a healthy body, with their lives intact and their children's lives intact as well. But we need legislation. They've spoken about how important it is for there to be a law, for there to be a policy, both at national and subnational level, that mandates people to report maternal deaths when they happen within their communities. You understand better now. Please use your platforms, use your voices, use your everything that you have to push for this. There's a bill currently in the National Assembly that's being pushed by the current Senate Committee of Health. Push for the law to be passed. And then when it is passed, use your voice and your platform to push for better understanding and for it to be implemented. So we've heard a lot of recommendations here. I like what was said about holistic community engagement, about male involvement. Thank you so much for asking those questions. And about trust. Dr. Wayemi, you are government, and you said we don't trust governments. Well, I mean, So there's a need to continue to engage with communities, to continue to build trust, for there to be legislation, for communities to understand the value of this as well, and to be a part of the process as it rolls out with MAMI and with the implementation of MPDSR. Please help me thank my esteemed panelists for sharing their thoughts, sharing their experiences. And please clap for yourselves as well. For everyone seated here, I assume, is very interested in maternal health, and you care about these issues. It's why you chose this breakout session to attend. So please clap for yourselves, and thank you so much, everyone.